Hello, my name is Jay, and as you know by now, I have cancer. And the purpose of these videos is, I'm not even sure which is primary, but primarily I think to guide those that might be going through similar things in their own journey. That would probably be primary. As I've said before, I have personally looked at these kind of videos well before I've had cancer, just to put myself in their shoes. I feel like I'm honoring those people that have dealt with such deadly situations, and sometimes good and sometimes not so good outcomes, and honoring them in that small way to at least put myself in their shoes and empathize with them, even though they may have never known I was there. Kind of an odd thing, but that's kind of how it felt. And it has prepared me. Watching those videos have prepared me for the unexpected situation where I myself had cancer. People's numbers come up every now and then, as we all know, and much to my surprise, I was a pretty healthy guy. I ate reasonably well, I was reasonably healthy, but there it is. I'm not sure if it was a tooth that started it or it was stress that started it. I've got a lot of stress in my life. I've got a business that requires my full-on attention. I have 6 rescue dogs at home that require my full-on attention before and after work. So there's a fair amount of stress, and it may have played a role. I had a tooth issue, which I talk about in the very first video, which could also have played a role, or maybe some combination of all of them. Just no way to be sure. May 13th was a big day, a really big day. This guy right here, I think I've got my pointing in the right place. This is the obvious culprit. This is a tumor on my tonsil. That is actually an image on the inside. Down at the bottom, let's see if I can get my finger right on this thing. Right there, where you see this cutout, that's actually where they took the biopsy of the tumor. They took quite a divot out of it. I hope they didn't piss it off, but that confirmed what it was, although the doctor knew at a glance. And I've got a lot of tests up till now. The ear, nose, and throat doctor, that biopsy, sent out to the laboratory, got the exact specific kind of tumor it was, which was squamous cell carcinoma. I'm getting better at remember what that is, and HPV positive. And there are some other descriptors of this tonsil tumor that have come out since then, which I'll provide for you as we move along a little bit. So let's talk about my experience at the Fred Hutch Center. Okay, we're parked. Let the games begin. This is the Fred Hutch parking lot. My sweetheart Tracy drove me down there and accompanied me through that process, and I was very grateful. It's so nice to have somebody that cares about you, that you care about, that's with you when this is going on. We went into the hospital, and I believe it was room C. After announcing our presence, answering a few of the same questions I always answer, went into room C. They put a hospital band on me, identifying me as a patient that can be scanned, I guess. And we went into a room where I sat down, and all of my time was spent in this one room. And the idea was supposed to be that 3 doctors would have seen me, and this was like the gold standard, from what I understand, where you have the surgical oncologist, the medical oncologist, and the radiation oncologist all visit you, one after the other, so you really get the big picture, and you can take from that what you need to make the decisions that need to be made moving forward. Unfortunately, one of the 3 were on jury duty, the medical oncologist, so I only got 2 out of the 3. Big disappointment for me. Kind of breaks my heart a little bit, because there you are, even though the odds of survival are very good, your life hangs in the balance. It's very important stuff, and you just wouldn't figure out jury duty would be a priority over what I'm going through. But be that as it may, that was the situation, and I can't pretend to know, when that transpires. She might have had no appointments previously. I just don't know. So the first person to come into that office was the radiation oncologist. And for those that aren't familiar, and I'm only now getting more familiar what these things mean, the radiation oncologist is the one that, directs the radiation beam at my neck and controls the intensity of that beam, the duration of that beam, and then over time how many of those types of treatments that I get. The doctor was a nice fella, very young. That really surprised me. I did notice it on his website. I dug into the background of every one of the doctors because I want to know who I'm dealing with, who is my life in the hands of. And I was a little bit apprehensive about his youth to begin with, and God, he looked younger in person. And he had a mask on that really made it difficult to communicate with him. I couldn't feel any sense of empathy. All I could see is his eyes, and it was a very unemotional, informative process. And I don't know how else to say that. He seemed like a good guy, and he may be extremely knowledgeable. I just don't know. But my takes, those were my takes as a patient and how I felt. I didn't feel the empathy. I didn't feel the intimacy. Although he spoke, quite knowledgeably, and he let me know what this process would look like, and let me know about potential side effects. And we'll talk about side effects, and I'm going to jumble them up a little bit because there were side effects to surgery, there were side effects to radiation. It seemed to me the biggest side effects to radiation, I'm going to feel a sunburn on the outside. I'm going to at some point feel like I've got a sunburn on the inside. Probable loss of taste, loss of feeling, things like that, potential swallowing problems. And some of these are short-term, and it can't be ruled out that some of these can be long-term, including loss of taste. I don't know what the odds are for one or the other. I think I have to be given worst-case scenario right down the line so that I understand what the possibilities are. So if they happen, I'm not completely surprised. Voice issues, voice change have all been indicated as potential parts of this process. And he probably told me how many times a week and what the duration is. I think it was 5 out of 7 days a week. I think it was up to 6 weeks or thereabouts that the treatment goes on. And he is specialized in something called proton therapy, which is a more recent form of radiation therapy. And the idea between proton therapy, or the goal there, is that it can affect that there's less fallout, there's less of the other tissue being affected by the radiation. It's more targeted, more precise. And so if we're going for this tonsil tumor that I showed you in the picture earlier, we're not, the radiation isn't bleeding through to the middle of my neck, trachea, everything else that's going on back there. And that's obviously a benefit. And so I certainly am interested in the proton therapy and would only really want proton therapy based on what the research that I've done thus far. So he also put a scope down my nose to take a closer look at what was going on. Since he is the one that's doing the radiation therapy, he wants to have a clear idea of what's happening. So it's about the size of the thickness of a toothpick, maybe a little thicker than a maybe toothpicks. And it's wired into, it's a wire with a camera at the end, and it's flexible, and you go up you went actually up both passages to see if one was better than the other, and this one seemed better than the other, and it went down in, and then all of a sudden I could see this beautiful picture of the inside of my mouth on the screen, and presumably he could control the dexterity of the device at the end, and it would point to different areas of my throat and surrounding tissue, and that was very interesting.
Down past your palate, this is the base of your tongue. As we flex the camera a little bit more to get around your palate, you start to see your tonsil. And then this is the tumor right here that starts to come into view.
Oh,
right
okay,
here.
yeah.
So it doesn't look like it's involving the base of tongue.
Wow, that's an ugly looking thing.
So the tongue is over there.
Yeah, this is the tongue.
Is that about the size of a pea or bigger or I can't.
What did you say?
Yeah.
Garbanzo bean or?
Yeah, it's probably about the size of the end of my pinky.
Okay.
Yeah, it's not.
It's fine,
And
good.
then this is.
This is the epiglottis, vocal folds.
Wow.
And you'll see that when you say E, your vocal folds come together nicely, symmetrically in midline.
It looks a little like a vagina. It's very interesting.
Let's see that.
All right, thank you. That it?
Of course. Yep.
And I think that was essentially it. He was probably in there for a good 40 minutes, if I were to guess, 30 to 40 minutes. And then he left, and the surgical oncologist came in. As the name implies, she'd be doing the slicing and dicing. Very conversely, no mask, which immediately just makes her more approachable. Kind, nice, attractive, not that matters at all. They were both attractive people. Not that matters absolutely not. I don't know why I say it, right? Human nature. But she was really informative, and she went through the extra step of describing for me what my head CAT scan actually looked like, what it meant. In the last video, I had AI try to interpret what all these slices meant in the CAT scan, because I certainly couldn't figure it out, and it was of great assistance.
So Jay, this is your scan from the 22nd, and it is an axial view, so that means that we're looking at it as though we're taking slices going down like this.
Okay.
So you're going to see your eyes and your nose here in a moment.
Right.
Okay, and that gives you a perspective there. Okay, now if we look here, you'll see that there is a little bit of fullness here in your right tonsil, and that is where the cancer is. Then you've got a couple of lymph nodes over here on the side.
So the right is on the left side, correct?
That's correct.
Okay,
yeah,
got it.
Anatomic right.
Yep.
Yeah. So then if we look over here on the right side, then you're going to see a couple of lymph nodes there. Now these look pretty cystic, and so that's usually a good thing. But there are a few of them that look suspicious. So 1, 2 right there for sure. Okay. That being said, there's nothing else here on the other side in the neck, which is important, and on the other side of the throat, which is
Can you
important.
show us the tonsil again? I'm not really sure I know what's.
Yeah, it's a little bit, I'll be honest with you, it's a difficult site to see because that area is very crowded. So it actually is right in here, right in there. It's a little bit obscured by some dental artifact,
Okay.
but you can see it there, and it's hiding in the little kind of pillars of your tonsillar fossa there.
Can you go back to the point where you identified where the trachea and the last one I wasn't sure where? Yeah, a little further.
Yeah, so
that's
this
down
is
where
the
you
voice
thyroid.
box here, and then
Okay.
we're going to look at that thyroid mass now. So you
That's
see
the
the thyroid
thyroid.
here, and you see again.
And what's that?
Yeah, so that is one of the lobes of the thyroid. This is the thyroid on the other side. This is the lobe of your thyroid on the left side, and that's where the nodule is that you had that FNA of. And so, this is unlikely to be related to the tonsil, and instead likely to just be a nodule that is large. I know it was biopsied and they couldn't get enough, sounds like it couldn't get sufficient cells to make a diagnosis, and that's common when there is a bit of a cystic component to the nodule.
Okay.
That being said, it's something that we can likely deal with at the same time if you want to.
Okay.
Okay?
Yeah, I'm purposely keeping you out of this sometimes. Would you prefer that?
Yep. Yes.
Okay, good,
Yeah,
good.
Yeah. So now I'm just going to talk to you about treatment here.
Okay.
I know Dr. Riviere spoke to you already.
Here now I had a doctor who's used to interpreting these things look at that CAT scan with me and say, okay, that's this and that's that and that's that, and she's putting labels on things that in some cases confirming what the AI had looked at, and in other cases shedding some new light on something that I was uncertain about. So I was really appreciative of that. She talked a lot about the possible worst case scenarios. She was very clear, and there's one that is actually potentially fatal. Some of the issues had to do with, again, speech impairment, because you're cutting a pretty good hole in there, and it's very close to nerves that control shoulder muscles and and a lot of things of importance. And if you bruise or cut or a nerve you could lose movement in this area, which I think comes back someday. But it actually, you got to put that together. Something in here can affect something out there. Certainly can affect speech. It can affect swallowing. In worst case scenarios, you could end up with a tube to feed yourself for the rest of your life, because you don't have an ability to swallow anymore. There's breathing tubes, a lot of heavy duty things. I don't have all of this, on the tip of my tongue, but all of these things were talked about. And I remember by the time she was done, I was into a whole new reality phase of what's going on in my life. And then she got to the point where you really want to make sure that when the surgery is done, that you stay near the hospital. You should plan on staying near the hospital. And I think the radiation oncologist said that same thing, because I think that between the two of them, they'd already kind of felt that I was going to be going the surgery route first. And the reason why is, as I have, they mentioned, I've since learned, is, but this area that they cut out back there, they use a robot. It's called TORS, T-O-R-S, transorbital robotic surgery, I think it is, which quite frankly looks like a couple of roach clips or wires that the end of a wire that you'd hold onto wire with those little clips, and they operate like hands instead of clips, so they're very dexterous. There's a lot of movement. They can go all kinds of different ways, and one holds onto tissue and pulls it a little bit back inside the mouth, kind of holds it back. The other one will start surgically removing tissue, and it looks like it burns it with an electric type of a device, or maybe a laser pulse. And as it burns it, it also cauterizes the tissue that's being burned. Bleeding in that area is obviously going to be prevalent because it's a highly vascular area, and so they suck up that blood as it's ongoing. So there's a lot going on in there, and they use these robots because you can't get hands back there, back in the back of, you just can't. It's not possible. And I guess in the old days, they literally used to crack the jaw and spread it open in order to get to that area. So I'm very thankful that I'm beyond that period in time. But still, the idea of having robotic things in there, now I guess the doctor is on the outside of the machine, controlling exactly what's happening. And she's been in this business a long time. I've done research on her, and am comfortable putting my life in her hands in that regard. But it's serious business. And then after it's all said and done, you can't really stitch it together, because you've got this crater, it may be this big, and you can't start bringing stuff from one side and pinching it up in the middle, because that's going to affect your ability to swallow and do the things that you normally do with your mouth. And it's very, very muscular in there as it is, and so you're moving and talking and you'll pull those things apart anyway. So none of it makes any sense to use stitches, and so they cauterize what they can, and then that tissue has to heal itself naturally. And I guess between the 5th and the 10th, at some point you get some kind of a yellow covering that covers all of that area. That's part of the healing process. There's a scabbing process that may not look quite like a traditional scab, but there's multi-layers to that healing process that happens. And there is I believe the number is between 5 and 8%. That outer layer has been described as sloughing off. and if it sloughs off, the bleeding, you get tremendous bleeding that starts anew, and you're in an emergency situation. You have to get to the doctors, you have to get to the emergency room, and they have to deal with that right away, that the bleeding can choke you out. You can't, it goes down the airwaves, and you're in serious trouble. So naturally that scares the hell out of me. And she told me that what they would do to forestall that or to minimize that is they tie off an artery that feeds the surgical bed that they would be working on as part of being in there. So they got to cut a hole in my neck, and that's just part of that process. Go in, tie off that vein that feeds that surgical bed, and that would minimize that from happening. And I inquired about that online, and it seems like they don't untie it, that there's enough other veins feeding that area to where that long-term everything gets what it needs and life goes on. So that's scary as hell, and that means I would definitely need to sleep somewhere nearby the hospital for a full 10 days. When she said it, I thought, well, that's kind of weird, but she said it's unlikely anybody in the Anacortes Mount Vernon area is going to be able to do anything for you if something were to go wrong. And so you really need to be near this hospital. And so if I get surgery, I'll certainly be scoping out my options there, and then being fearful that it happens when I'm asleep. You just don't know. The odds are against it. It's the 5 to 8% to begin with, and of those, the number is less than 1% that it's actually fatal. So it's a small number, but it's there. And then part of that surgery is that they would, and also she seemed to be talking about a pretty big slice of the neck. They would be going in and removing the lymph nodes, not just the two that have been discovered to have it, but all the lymph nodes in that whole general area, which to me would seem like it would compromise my immune system moving forward on some level, because they're there for a purpose, which is part of the immune system. But talking to Tracy and others, she said there's you get so many of the darn things that there may be some compromise, but the reality is you still be in good shape. Obviously weakened a little bit in this area. How can you get away from that? I mean, if it's filtering the cancer out initially, that advantage would be gone. But that is part of the process, because it might just be a little bit of cancer in some of those other ones, and it's not detectable. Then you go through all this work, and you find out you still have cancer in another lymph node. It just makes sense to pull them all out while you're in there. I guess that covers it for the surgery. She said if you pull your collar up, the scar won't be visible. She's kind of chuckling about our podcast and that kind of stuff. It's like, I told her I'll just tell them I got it in a bar fight or in jail. Somebody tried to cut my throat, or I'll make something up to make it sound more interesting. When all was said and done, with her, we moved on to the speech pathologist, who, which I forgot was even part of the picture that day. The one that we're missing, by the way, the medical oncologist, would have talked to me about chemo. And chemo is where the drip into your veins, that toxic substance that goes through your entire system, but kills the cancer cells. Well, it obviously kills other cells as well. So chemo and radiation together do the damage that they've done for however many decades that they've been doing it. The proton therapy will minimize it. The chemo will have fallout. I'm sure hair falls out and all the things that you hear about that goes along with all that. But I haven't talked to the medical oncologist yet, so that appointment is on the 20th. I'll find out more about that. And before we talk about the speech pathologist, it really, to me as a layperson right now, looks like I'll be hearing from 3 different doctors, and I need to make a decision, right? I need to which way I want to go. The surgeon told me that that there's no, that there, I believe this is what I understood from her, that there is no real benefit from any more than 2 of the 3 possible treatments. So either surgery and radiation, radiation and chemo. I don't know if surgery and chemo is on the list, but 2 out of the 3 will do the job. There's no evidence that getting all 3 improves the outcome. So I'll be picking from that menu. The surprising part to me is, and research online seemed to indicate that there will be some kind of a tumor board in this process, because at present the radiation doctor is telling me what's going to happen with radiation. The surgeon is telling me what's going to happen with surgery. They both clearly feel that those things are necessary, both of them in each case, and maybe the chemo doctor will too. And in which case I'm left to choose between the what's on the menu. And I'll research it, and I can do that. It's uncomfortable, but that's what has to be done. But I've also been shown that there might be some kind of tumor board where a group of experts looks at these 3 possibilities, looks at my particular case very closely, and the tumor board forms their own opinion about what the best course of action is, so that I get what would be an unbiased, unprejudiced opinion from an outside group that says, okay, we think this is the course that's in your best interest. I have not seen any evidence of that thus far. That hasn't been introduced to me, that person or that group. But it seems like it's a thing, and I'm just insulated from it at this point in time, and I'll probably, I'll ask about that to see what's available to me there. So the speech pathologist then comes into the office, and just a kind, caring person, and then it just matters to feel that when you're in such a vulnerable position. Now, she's not going to be responsible for fixing anything per se. At least not the things that will allow me to live or die. But she will have a lot to do with the recovery process and the rehabilitation of normal swallowing, normal talking, my singing voice. God knows, as good as I am at karaoke, that I don't want to lose my singing voice. And so she was let's say, very kind. And one of the things that she offered to do, she didn't require it, but she offered, would you like to have a pre, pre-surgery or pre-everything analysis of your swallowing and this, that, and the other, so that we have a baseline. She says, it's not really required, but probably a good idea. But she kind of left it up to me, and I'm like, well, I kind of want to leave it up to you. What do you think? I mean, is this going to benefit me to have this baseline here now? And it was just kind of a funny thing where she wasn't really pushing it, and I really wasn't sure if I should or not. So in the final analysis, I decided to be more decisive and say, sure, it's free, it's on the menu, let me have it, whatever it is. And so she seemed to agree and came back in with some applesauce and some blue food coloring and some different things that would be easy to see as she's taking the videos. She also had to put one of those scopes down my nose. At one point, it felt like it was being jabbed into some tissue back there, and I really had to react and stop her from pushing it any further, because it wasn't a hole. We were no longer navigating a hole. We were creating a hole where one shouldn't be. And no, she was responsive to that, and she pulled it out and put a little lidocaine on there to numb things up a little bit better, and threaded it. We tried this hole, and then we went back to that hole, and anyway, we got it figured out, got it threaded down there, and then I swallowed some liquid, and I could see it on the video myself, the process of swallowing the liquid. it was interesting to me. I love the science. I'm very interested in all the science, and to be able to see this thing called an epiglottis. We've all heard of an epiglottis. It's that thing that when you breathe, it stays open and you breathe air. But when you swallow, it closes so that nothing goes down your air hole and everything goes down your esophagus. Well, we're all left to just visualize that from, color textbooks when we were children. And, it kind of looks like a toilet bowl lid, right? It opens or closes depending on what you need. You can't figure out anything more than that.
This is the back of your throat. So back wall of your throat, your tongue moving right here. That's your tongue. We're looking at your voice box right here. So these are your vocal cords, the 2 white strips moving in and out together.
Right.
Very nice.
Wow.
And these are the walls of your throat. So this is actually the left side and this is the right side. So the view is flip-flopped.
Okay.
You're about to swallow some liquid, so you'll see some blue liquid. Right? The black kind of hole that you see below the vocal cords is your airway going down to your lungs. So that's your trachea.
Okay.
Behind it is your esophagus, or the food tube pipe that goes down to your stomach. It's closed now, and it will open while you're swallowing. And there was the first swallow. So we can see a tiny bit of blue liquid, but otherwise it went right on down and you couldn't even see it. That's what we want.
Gotcha.
So you can see the blue liquid moving in your throat, but nothing left over or down in your airway.
I'm going to do this again. It's a little bit more liquid this time.
So when you swallow, it turns white, or we can't really see because you're swallowing around my camera.
Gotcha. That's a funny thing to see.
The blue liquid is you swallowing it,
Right?
but otherwise, nothing left over or in your airway, which is
now
good.
sip from the cup. So 1 sip.
And that's me looking at the inside of my windpipe there, or my...
Yeah, good question. We're right above it.
Okay.
The black you can see is the start of where your windpipe is.
Okay.
Although we're not directly in
Gotcha,
it.
gotcha.
We're just kind of sitting right behind your throat.
That's funny.
And that's you laughing.
Yeah, a little bit.
A little bit of cracker left over in your mouth.
You just gentle breathe in for me. All right, it's 1, 2, 3 coming out.
And we're done.
All right.
It was interesting to see that epiglottis. It's much larger than I would have thought, and how it seals things up and drops down again. The voice box, was amazing to me. To be able to see my vocal cords, which, I forget exactly what's behind the vocal cords and how that works, and this whole process of vocal cords, esophagus, and trachea, and all they're all in that same area. But I'm guessing that the vocal cords are covered by the epiglottis in the process of swallowing. Yes, it would have to be. But when I'm talking, they've got the microphone focused on my vocal cords, and I'm talking, and I can see my vocal cords coming in and out. One of the first things that I thought of when I saw my vocal cords, because it's this pink fleshy area around it, it's shaped kind of like a diamond, and I said, Jesus, that reminds me of a vagina. And Tracy was like, oh God, I can't believe you said that. And the doctor, at this particular time, actually, it was with the first doctor when that came out, the radiologist, and he didn't seem to get my sense of humor.
It looks a little like a vagina. It's very interesting.
So these videos of my insides happened at different times between the first radiologist and the speech pathologist. But it was just very interesting. And when I would laugh, they would kind of bounce back and forth, and every sound I made and I'm making is a series of this thing going like this. And sometimes when I laugh, it bounces. I mean, it's like a reverberating thing. And it really occurred to me for the first time that what I'm looking at is a wind instrument. I mean, air's coming through it. It's closing to change the tone that comes out of that hole and it has such precision to it, and it's so flexible and capable. It can go slow, it can go very fast. If you hum, it does a different thing. It vibrates as you're doing what you're doing. Very impressive. Knowing what I know now about the wind instrument that is your vocal cords, by actually seeing vocal cords, it gives you a whole new respect for the sounds that it's capable of making and that you'd be capable of making through it, just like any musical instrument. So enough about the vocal cords. It's just all very fascinating. It was interesting, of course, to see the tumor up close and personal. There's the thing that is invading my mouth and is causing me all this grief. And I remember getting a sense of its. It looks much bigger in the picture than it actually is, but I remember seeing it was vascular. I could see the veins inside of it, so it's being fed as it grows. It's forming new tissue, and there's these white bumps, these white spots. They almost look like sesame seeds that are part of it, and I don't know what they're about, but they're part of it. And so that was all very interesting. But the speech pathologist got done doing what she needed to do, pulled the thread back out of my nose. By the way, the applesauce was blue as well, but it tasted just like applesauce. And I got to eat a graham cracker. So all of these things mattered in the way that I process, chew, absorb saliva. I guess the graham cracker would tell her how much saliva comes in, right? And so they know if the salivary glands are working the way they're supposed to. We got the swallowing, we got the of liquid and food, so I guess it covers all the bases. As I said, then I said goodbye to her. I think I actually gave her a hug on the way out the door, and was grateful for her and me, and it was just a bit of a connection there that I was grateful for. After all of that, it took about maybe 2.5 to 3 hours that we were at the hospital. When we were done, we went to Buca di Beppo's to celebrate down in Seattle. We had a nice big meal, and I had a couple of Irish coffees and a cannoli for dessert. I think it was linguine and shrimp, kind of a combination. Very, very good. So we celebrated in that way. And just a funny aside, and not really funny, but I went to pay for the meal, and Tracy reached over to the whole booth, and she grabbed my wallet, rips it out of my hand. She says, "You're not paying." I said, "Today's your day." And she takes the wallet, puts it off to the side. It's like, okay. So she paid, and I was grateful, and we went home. Later on that evening, I asked her for my wallet back. She said, "Well, you don't have it?" I said, "No." "Why would I have it? You took it off me." As it turns out, she took it off me, and she left it on the bench right beside where she was sitting. I thought she stuck it in her purse or her jacket or something else, and there it stayed. She called back and found that it was still there, and so the next day while I went to work, she had a lunch date with her son who also lives in Seattle, or made a lunch date with his son. Fortunately, was able to kill 2 birds with 1 stone. Drove back to Seattle, and got my wallet back. So moving forward, this whole thing is obviously become very real. It wasn't real until that meeting. I thought little chemo, little radiation, it's small enough, stage 1. It'll go away slowly but surely, and Jay will be no more the worse for it. These other concepts, especially surgery, very scary. So I think I'm going to try to find out if that's avoidable. The upside of surgery, though, is they get a big piece of the tumor out, and that can't be lost on me or you. And so they have less to radiate. Success is, if they've got rid of the lymph nodes, they got rid of the tumor, there's a lot less angry cancer running around to begin with. They don't have to radiate as much or inject as much chemo to finish the job. And assuming this heals normally, now we're a good bit ahead of the game. And you know, because if they use water radiation over time, radiation itself is cancerous. I mean, it causes problems. So too much is not a good thing. Too much over a long period of time is not a good thing. Too much chemo in your veins is not a good thing. So if it minimizes those, surgery has obvious benefits. So I've got to weigh all these things, and I'll be interested to hear the thoughts of a tumor board or a third party, and I will drop all of this into AI as well, and get opinions from different AI avenues as to what the best choice is for me, even after hearing from a tumor board. I am now moving into the treatment phase. I guess that's putting in a nutshell, that's the reality of my situation. I'm now moving into the treatment phase. It's ugly. It's no longer just being talked about. It's no longer just making videos. It's real pain is going to be inflicted upon my body, and I have to deal with whatever that fallout is. It's not fun, but if I put it into perspective, there are people with, you know, lung cancer, blood cancer, bone cancer, breast cancer, brain cancer, pancreas cancer, cancers that are infinitely scarier than the cancer that I'm dealing with and at the level that I've caught it. You know, if I ignored it for a year, I might have had a very different situation on my hands. But at this stage, I still need to just put things in perspective, be grateful, and make the best choices I can and move forward. That's all I got. Thanks for watching. Stay tuned. Till May 20th, I'll have another meeting with the medical oncologist. May 19th with the dietary side of this, which they'll be preparing me on what my diet should look like as I go through these processes. So sometime after May 20th will be the next video. Thanks for watching. Bye-bye.